Hello everyone. Today we will learn about knee joint. Knee joint is important topic. It is repeatedly asked in exams for 10 marks. Okay. Knee joint type. The knee is the largest and more complex joint of the body. The complexity is due to the fusion of three joints in one. It is formed by the fusion of lateral femorotibial, medial femorotibial, and femoropatellar joints. Okay, it is compound synovial joint incorporating two condylar joints between the condyles of the femur and tibia, one saddle joint between the femur and patella. Articular surface. The knee joint is formed by the condyles of the femur, condyles of the tibia, and third one is patella. The femoral condyles articulates with the tibial condyles below and behind with the patella in front. Lower end of the femur and patella seen from below. Patellar surface of the femur, patella areas that come in contact in external flexion condition, medial condyle of the femur. Okay, this diagram shows the patella seen from the behind, as well as ACL, PCL, medial condyle of tibia, posterior horn of lateral meniscus, anterior horn of the medial meniscus, posterior cruciate ligament. Okay. Now we will discuss regarding ligaments. There are total 11 ligaments in the knee joints. First, fibrous capsule is common in all joints. Ligamentum patelli, TCL, tibial collateral ligament, or also termed as medial collateral ligament, fibular collateral or lateral ligament, oblique popliteal ligament, arcuate popliteal ligament, anterior cruciate, ACL and PCL, posterior cruciate, medial meniscus, lateral meniscus, and last one is transverse ligament. Okay. Now we will study individual ligaments of the knee joint. First, fibrous capsule. The fibrous capsule is very thin and is deficient anteriorly, where it is replaced by the quadriceps femoris. Now I hope everyone knows quadriceps femoris, rectus femoris, vastus lateralis, medialis, and intermedialis. Okay, the patella and the ligamentum patelli. Femoral attachment. It is attached about half to 1 centimeter beyond the articular margins. The attachment has three special features. Anteriorly, it is deficient. Posteriorly, it is attached to the intercondylar line. Laterally, it encloses the origin of the popliteus. Okay. This diagram shows the laterally covering of the fibrous capsule, tendon of popliteus, FCL ligament, lateral meniscus. Okay, ligamentum patelli. Now regarding tibial attachment. It is attached about half to 1 centimeter beyond the articular margins. The attachment has three special features. Anteriorly, it descends along the margins of the condyles to the tibial tuberosity, where it is deficient. Posteriorly, it is attached to the intercondylar ridge, which limits the attachment of the posterior cruciate ligament. Posterolaterally, there is a gap behind the lateral condyle for passage of the tendon of the popliteus. Here in white line you can see blue line shows the anterior cruciate, blue line shows the condyles of the femur and tibia, and between the condyles of the femur and tibia there is gap for the tendon of the popliteus. Some terms applied to the parts of the capsule are as follows. Coronary ligament. The fibrous capsule is attached to the periphery of the menisci. The part of the capsule between the menisci and the tibia is sometimes called coronary ligament. So you have to remember that the part of the capsule between the menisci and the tibia is sometimes called the coronary ligament. Short lateral ligament. This is a cord-like thickening of the capsule deep to the FCL, fibular collateral ligament. The capsular ligament is weak. It is strengthened anteriorly by the medial and lateral patellar retinacula, which are extensions from the vastus medialis and lateralis. Laterally by the iliotibial tract and medially by the expansion from the tendons of the sartorius semimembranous and posteriorly by the oblique popliteal ligament. This is the anterior view of the knee joint. First, you can see the ligamentum patellae, which is the insertion of tendon of the quadriceps femoris. On laterally, vastus lateralis, medially, vastus medialis. Okay. Opening. The capsule has two constant gaps, one leading into the suprapatellar bursa. Okay, this is one leading to the suprapatellar, above to the patella, suprapatellar bursa. Another for the exit tendon of the popliteus that I have shown in previous diagram, in this diagram. Okay. Now, second ligament, ligamentum patelli. This is the central portion of the common tendon of the insertion of the quadriceps femoris that I have told before few seconds. The remaining portions of the tendon from the medial and lateral patellar retinacula. It means besides the tendon of insertion of the quadriceps femoris, there are medial and lateral patellar retinaculum. Retinacula, this terminology we have seen in terminology class. The ligamentum patella is about 7.5 centimeter long and 2.5 centimeter broad. It is it is attached above to the margins and rough posterior surface of the apex of the patella and below to the smooth upper part of the tibial tuberosity. In every PPT, I have done some bold letter, so you have to focus on that words and you have to remember that. Like the example, in this I have bold the apex of the patella and tibial tuberosity, so you have to remember the course or attachment from apex of the patella to the tibial tuberosity. Ligamentum patelli is attached. Okay. The superficial fibers pass in front of the patella. The ligamentum patelli is related to the superficial and deep infrapatellar bursa and to the infrapatellar pad of the head. Suprapatellar bursa that we have seen. Now below the ligamentum patelli, you can see the some yellow color pad. So this will be the infrapatellar pad. Okay. And in this diagram, you can see the quadriceps tendon as well as medial patellar retinacula, and there is written that patellar retinacula and two arrow. So we should consider as a medial and lateral patellar retinacula. Okay. This is the diagram of the normally ligamentum patelli, ACL, meniscus, cartilage. Okay. Now TCL or medial collateral ligament. This is long band of great strength. Superiorly, it is attached to the medial epicondyle of femur just below to the adductor tubercle. Inferiorly, it divides into anterior and posterior parts. Here medial collateral ligament. The anterior or superficial part is about 10 cm long and 1.25 cm broad and is separated from the capsule by one or two bursa. It is attached below to the medial border and posterior part of the medial surface of the shaft of the tibia. It covers the inferior medial genicular vessels and now and the anterior part of the tendon of the semimembranosus and is crossed below the tendon of the sartorius gracilis and semitendinosus SGS that forms a gyros formation. Posterior part. Posterior part of the ligament is short and blends with the capsule with the medial meniscus. It is attached to the medial condyle of the tibia above the groove for the semimembranosus. Morphologically, the tibial collateral ligament represents the degenerated tendon of the adductor magnus muscle. This question can be asked in the viva. Okay, so mind it. Okay, FCL, fibular collateral ligament, strong and cord-like, length 5 cm, superiorly attached to the lateral epicondyle of the femur, just above the popliteal groove. Inferiorly, it is embraced by the tendon of the bicep femoris and is attached to the head of the fibula in front of the apex. Okay, its apex. Morphologically, it represents the femoral attachment of the peroneus longus muscle. Okay, now in this ligament, you have to remember lateral epicondyle of the femur just above the popliteal groove and head of the fibula in front of the its apex. Okay, in this diagram you can see the FCL, lateral condyle of the femur just above the popliteal groove, attached to the head of the fibula in front of its apex. Okay, fifth one, oblique popliteal ligament. This is an expansion from the tendon of the semimembranosus muscle. It runs upward and laterally, blends with the posterior surface of the capsule, and it is attached to the intercondylar line and lateral condyle of the femur. It is closely related to the popliteal artery and is pierced by the middle genicular vessels, nerve, and the terminal part of the posterior division of the obturator nerve. This is the oblique popliteal ligament. We can see it is the expansion of the semimembranosus muscle, runs upward laterally, intercondylar area and lateral condyle of the femur. Okay. Arcuate popliteal ligament. This is a posterior expansion from the short lateral ligament. It extends backward from the head of the fibula, arches over the tendon of the popliteus, and it is attached to the posterior border of the intercondylar area of the tibia. Okay, arcuate popliteal ligament. Here, head of the fibula to the intercondylar area of the tibia. Arcuate popliteal ligament, head of the fibula below to the intercondylar area of the tibia. Okay, it goes upward and to the intercondylar area of the tibia. Okay, arcuate popliteal ligament. Cruciate ligaments. Okay, these are very thick. Cruciate means ACL and PCL. Okay, anterior cruciate ligament and posterior cruciate ligament. These are very thick and strong fibrous bands which act as direct bonds of union between tibia and femur to maintain the antero-posterior stability of knee joint. They are named according to attachment on the tibia. ACL begins from the anterior part of the intercondylar area of the tibia, runs upward, backward and laterally, and attached to the posterior part of the medial surface of the lateral condyle of the femur. It is taut during extension of the knee. ACL. A A stands for anterior part of the intercondylar area of the tibia. C should keep left now. L indicates the its second attachment, lateral condyle of the femur. Okay, lateral condyle of the femur. It means here I am giving you trick to remind it to ACL. A stands for anterior part of the interior condyle area of the tibia. C, leave it. L stands for the lateral condyle of the femur, and specific medial surface of the medial surface of the lateral condyle of the femur. Okay, now just you have to remember the ACL. Exact oppositely you go for the PCL, posterior cruciate ligament. Okay, now we will see regarding posterior cruciate ligament. Begins from the posterior part of the intercondylar area of the tibia. In ACL we have seen anterior part of the intercondylar area of the tibia runs upward, forward and medially. It indicates its course, direction of the tendon, and is attached to the anterior part of the lateral surface. In ACL we have seen medial surface, here lateral surface of the medial condyle of the femur. Okay, it is taught during flexion, it was extension of the knee. Okay, it is taught during flexion of the knee. These are supplied by medial genicular vessels and nerves. Okay. Okay, ACL you can see from anterior intercondylar area of tibia and goes ACL. L stands for lateral condyle of femur. P, posterior part of the intercondylar area of the tibia, PCL. But here we have to remind L opposite medial condyle of the femur. Okay. Now 9 and 10 menisci or semilunar cartilages. The menisci are two fibrocartilaginous discs. They are shaped like crescents. They deepen the articular surfaces of the condyles of the tibia and partially divide the joint cavity into upper and lower compartments. Flexion and extension of the knee take place in the upper compartment, whereas the rotation takes place in the lower compartment. Each meniscus has following. Okay. Diagram shows the medial and lateral meniscus and its horn, anterior horn, posterior horn, inner border, outer border. Okay. Two ends, both which are attached to the tibia, anterior and posterior end. The outer border is thick, convex. Here we can see outer border is thick, convex, inner border is thin. Okay. Concave and free. Two surface. The upper surface is concave for articulation with the femur. The lower surface is flat and rests on the peripheral 2/3 of the tibial condyle. The peripheral thick part is vascular. The inner part is avascular and is nourished by synovial fluid. Okay. The medial meniscus is nearly semilunar, being wider behind than in front. The posterior fibers. Now you have to remember the difference between the medial meniscus and lateral meniscus, like shape, its end, thickness, etc. Okay. The medial meniscus is nearly semicircular in shape, being wider behind than in front. The posterior fibers of the anterior end are continuous with the transverse ligament. Its peripheral margin is adherent to the deep part of the tibial TCL, tibial collateral ligament. The lateral meniscus is nearly circular. The posterior end of the meniscus is attached to the femur through the meniscofemoral ligament. Okay. The tendon of the popliteus and capsule separate this meniscus from the fibular collateral ligament. Generally, they ask you the difference between the medial meniscus or if specimen is there, menisci medial and lateral, then identify the medial and lateral meniscus and explain it. Okay, so you have to remember the characteristics of the meniscus, of medial and lateral shape, border, thickness, ends, okay, attachment, etc. The more medial part of the tendon of the popliteus is attached to the lateral meniscus. The mobility of the posterior end of this meniscus is controlled by the popliteus and by the two meniscofemoral ligament. Okay. This diagram shows the difference between the medial and lateral circular shape, C shape, structure forming 3/5 of the ring. The anterior and posterior horns are close to each other and near the insertion of ACL. Okay, here if there is ACL, then here will be PCL. Okay, anterior horn attached to the tibia, front of the tibia in front of the intercondylar eminence. Posterior horn attached to the posterior aspect of the intercondylar eminence in the front of the posterior attachment of the medial meniscus. Okay, like that you have to remember the difference. Now, sometimes it can be asked that write down the function of the menisci in 2 marks. They help in making the articular surface more congruent. Because of their flexibility, they can adapt their counterpart to varying curvature of the different parts of the femoral condyles as the latter glide over the tibia. The menisci serve as shock absorber. They help in lubricating the joint cavity. Because of their nerve supply, they also have a sensory function. They give rise to proprioceptive impulses. This is new word. Proprioceptive means a movement of eyeball according to position, joint movements. Okay, that you have to remember what is proprioception. Now, transverse ligament. It connects the anterior ends of the medial and lateral meniscus. In this diagram, you can see the transverse ligaments which connect or which bridge the anterior end of the lateral and medial meniscus. Bursa around the knee. There are 13 bursa, 4 anterior, 4 lateral, 5 medial. Anterior, subcutaneous prepatellar bursa, subcutaneous deep infrapatellar, suprapatellar, lateral. At least you have to remember the numbering of the bursa. Okay, because 13 it can be asked in viva. A bursa deep to the lateral head of the gastrocnemius, which can be seen during dissection. Bursa between the FCL ligament of the bicep femoris, bursa between the FCL ligament and the tendon of popliteus, bursa between the tendon of the popliteus and lateral condyle of the tibia. Medially, a bursa deep to the medial head of the gastrocnemius. The unserine bursa, H shape, is a complicated bursa which separates the tendons of the sartorius, gracilis, and semitendinosus from one another from the tibia and from the TCL ligament. Okay. Third one, bursa deep to the TCL ligament. Fourth, a bursa deep to the semimembranosus. Fifth, occasionally bursa is present between the tendons of the semimembranosus and semitendinosus. Okay. Now relations of the knee joint. Anteriorly, anterior bursae, ligamentum patelli, patellar plexus of nerves. This diagram shows the relations of knee joint. Posteriorly at the middle, popliteal vessel, tibial nerve, middle genicular vessel and nerve. Posterolaterally, lateral head of gastrocnemius plantaris, common peroneal nerve. Posteromedially, medial head of gastrocnemius, semitendinosus, semimembranosus, gracilis, popliteus. Medial is SGS, sartorius, gracilis, semitendinosus, great seminous vein, semi-membranosus, inferior medial genicular vessel, laterally bicep femoris, tendon of origin popliteus, inferior lateral genicular vessels and nerves. Okay, now we will discuss regarding blood supply. Okay, the knee joint is supplied by the anastomosis around it. Five genicular branches of the popliteal artery, the descending genicular branch of the femoral artery, the descending branch of the lateral circumflex femoral artery, two recurrent branches of the anterior tibial artery, the circumflex fibular branch of the posterior tibial artery. Nerve supply: femoral nerve through its branches to the vasti, especially the vastus medialis, sciatic nerve through the genicular branches of the tibial and common peroneal nerve, obturator nerve through its posterior division. Okay, at least remember the name of the nerve: femoral nerve, sciatic, obturator nerve. Now, movements of at the knee joint. Active movements at the knee are flexion, extension, medial rotation, and lateral rotation. Flexion and extension are the chief movements. This take place in the upper compartments of the joint above the menisci. This diagram shows the movements of the knee joint: flexion of the leg, extension of the leg, adduction of the thigh, abduction of the thigh. Okay. Now rotatory movements at the knee are small range. Rotation take place around vertical axis are permitted in the lower compartment of the joint below the menisci. Rotatory movements may be combined with flexion and extension. Locking and unlocking of the joint. Locking is mechanism that allows the knee to remain in the position of full extension as in standing without much muscular effort. It means whenever we are standing, it is the locking position of the knee joint. The lock knee joint can be flexed only after it is unlocked by the reversal of the medial rotation, that is bilateral rotation of the femur. Okay. Locking and unlocking also asked in Viva. Clinical anatomy. Structurally, the knee is weak joint because the articular surface are not congruent. The tibial condyles are too small and shallow to hold the large convex femoral condyles in place. The femoropatellar articulation is also quite insecure because of the shallow articular surface and because of the outward angulation between the angle between the long axis of thigh and of the leg. Okay. The stability of the joint is maintained by the number of factors. Cruciate ligaments maintains the position antero-posterior stability. The collateral ligament maintains side-to-side stability. The factors strengthening the capsule have been enumerated earlier. Okay, that we have discussed. The iliotibial tract plays an important role in stabilizing the knee. Now we will discuss regarding deformities of the knee. Genu valgum and genu verum and valgum. Okay, the angle between the long axis of the thigh, that of the leg may be abnormal and leg may be abnormally abducted. Genu valgum or knock knee. Abnormally adducted genu verum or bony. This may occur due to the rickets and posture or as congenital abnormality. Now I will show in the diagram. Genu valgum. You can easily Remember this, applied by this diagram. Okay, rum and gum. Okay, disease of the knee, osteoarthritis, and infection may be associated with collection of the fluid in the joint. This gives rise to the swelling above and at the sides of the patella. Okay, the patella appears to float in the fluid. Okay, osteoarthritis, in Ayurveda, Sandhivat, Amvat, okay, constructions. These are the applied aspect of the Janusandhi. Bursa around the joint may get filled with the fluid, resulting in the swelling. Injuries to the knee, meniscus strains in slight flex knee, as in kicking football. The meniscus may get separated from the capsule or may be torn longitudinally, transversely. Okay, the medial meniscus is more vulnerable to the injury than the lateral because of its fixity to the tibial TCL ligament, and because of greater excursion during the rotatory movements, the lateral meniscus is protected by the popliteus, which pulls it backward so that it is crushed between the articular surfaces. Injury to cruciate ligaments are also common. The anterior cruciate ligament is more common damage than the posterior. It may be injured in violent hyperextension of the knee joint, in the anterior dislocation of the tibia. The posterior ligament is injured in the posterior dislocation of the tibia. The injury may vary from simple sprain to complete tear. Tear of the ligament leads to abnormal anteroposterior mobility. The injuries to collateral ligaments are less common, may be produced by severe abduction and adduction strains. Okay, thank you everyone. Okay, wherever you have difficulty, just go to the text or further detail to it. Okay, thank you.